First of all, good evening all in this hour where is normally the dinner time for most of you. Thank you for being here with us. Konuş Konuşmacı duyulmuyor sesi. Lütfen kontrol edebilir miyiz?
Bırak bırak.
Again, nurses in the hospital, uh, they should give information about the administration of drugs, and they are responsible for that. And other medical personnel are responsible for drug use as well. Not only the medical personnel, but also patients and patient relatives are responsible, and they are informed about the drug use, and it actually determines the success rate of the treatments. So medication actually is not the determining factor there, but the information provided to the patients and patient relatives about the drug use is what we focus on. Again, producers, authorities, and others, media, academy, are really effective on rational drug use. And it is not only limited to that. Authorities, for example, you may prescribe a drug for your patient, but if the authorities do not allow the use of these medications, that could be a problem. Other factors include media, academy, etc. These all affect, these are among the factors that affect drug use. We talk about the rational drug use, but there's also an irrational drug use. This is important so that we can understand the importance of rational drug use. So, what does this mean? Irrational drug use is an important problem worldwide, and it is very prevalent problem. More than 50% of all medicines worldwide are prescribed, dispensed, or sold inappropriately. This means that our treatments and 50% of our treatment fail to take them correctly. And this means actually 50% of our treatments are in vain because they are not appropriate because of the irrational drug use. This is a huge ratio. And there is also another aspect. About 1/3 of the world's population lacks access to essential medicines. So this is like the two sides of a coin. So it's a two-dimensional issue. Again, looking at the budget in terms of medicines, of course, healthcare is one of the biggest items on the budgets of states, and this is probably the second biggest national expenditures. So, how much do we spend on healthcare? When you look at the developed countries, you can see that the 10 or 20% of the total budget constitutes healthcare expenditures, and in developing countries, it's about 20 to 40%. Again, the differences could include that developed countries, for example, usually are the producers of the healthcare system components or medicines, so they don't really spend anything outside of their system. But developing countries are more dependent on the exterior factors or more dependent on other countries or other systems. That's why this ratio increases in developing countries. So, what are some common examples of irrational drug use? And the most prevalent example we can give is the polypharmacy or uh, unnecessary polypharmacy, let's say. It means the use of too many medicines by patients or per patient. And the next thing is the second one is the inappropriate use of antibiotics, which is actually the reason why irrational drug use term came to being. So, inappropriate use of antibiotics, often in an inadequate dose for non bacterial infections. Sometimes the active ingredient, for example, could be right, but the dosage could be wrong. That is also included in the irrational drug use. And there is also an overuse of injections when oral formulations would be more appropriate. Uh, some people prefer using injections, and this actually creates an over expenditure in terms of the medications. So overuse of injections when oral formulations would be more appropriate is another example to irrational drug use. The next item you can see here is the failure to prescribe in accordance with clinical guidelines. So the more you follow clinical guidelines, the closer you come to rational drug use. And also, if you stray away from clinical guidelines, then your possibility to use drugs irrationally increases. Inappropriate self medication is another factor, which is actually maybe it is less or higher among our country or our population. People usually tend to buy medications based on what they hear from people around them, or they maybe decide which medication to take without consulting a healthcare professional, but because they took the medication beforehand for something else or for the similar causes, and they self-medicate, unfortunately. Again, there's another issue, which is the treatment selection could be inconsistent with clinical guidelines. This is again basically the same thing with the following the clinical guidelines. Also, inappropriate choice of novel drugs or being careless in drug use, in terms of the administration route or dosage, etc. These are included in the lists for inappropriate or irrational drug use. When you look into the factors affecting drug use, there are four main areas. First of all, the policy, legal and regulatory framework, prescriber, dispenser, and workplaces. And on the other side, there is the patient and the community. And the fourth one is the drug supply system. So this is actually, it comes to whatever drug the prescriber might prescribe, it comes down to patient understanding the use or the correct use of the medication. Authorities also play an important role. For example, you can ask for a certain treatment, but it could not be included in the insurance system of the state of the country. So this could be a hindrance in you using certain drugs. Also, with the drug supply system, we happen to see this in our country. Some drugs are unfortunately not accessible for people, and these are the factors affecting drug use. So, we look at them on a factorial basis. So, what can change the drug use habits that we have? First of all, informational areas. Lack of information is a problem, or based information is another problem. Here you can see there are some factors related to workplace. The overworking or overload in offices, in workplaces. Again, there are work groups, for example, actually affect your behavior regarding drug use. If we were to give an example for this, your workplace relationships with your colleagues, for example, even these could affect your drug use habits. And also there are some personal factors that affect your drug use, such as cultural beliefs or patient demands or acquired habits. These are all effective factors in terms of rational drug use. Yes. So when we look at the causes of irrational drug use, we have three main classes. One, the other one is prescription, and the next one is the dispensing of drugs. And the factors related to diagnosis is that we start with the inadequate examination of patient. Of course, under the conditions in Turkey, sometimes physicians might not have enough time to adequately examine the patient. So this is actually one of the basic reasons, main reasons for irrational drug use. The second one is the incomplete communication between doctor and patient. So if you don't have a healthy relationship, healthy communication with the patient, healthy or correct diagnosis, or your chances of a correct diagnosis decreases with incomplete communication. Another thing is the lack of documented medical history. The more you know about the patient's history, the more you have a successful diagnosis. Again, inadequate laboratory is another factor. Maybe not in psychology, but in other branches, it is important again. When we look at the other title, which was prescription, the factors include underprescribing. Sometimes some physicians, some doctors, maybe keep the distance between themselves and medication a little more than it needs to. When you look at it on a case basis, it's not always a negative outcome, but when you look at when you look at it from the rational drug use perspective, underprescribing is a problem. Also, incorrect prescribing is another factor. It causes ideal treatment, of course. In our country or in countries such as our country, there is a problem of extravagant prescribing, which actually promotes more drug use. The more extravagant prescribing doesn't mean that the treatment would be better or more successful, and it is not always the case. So we need to keep that the amount and the number of drugs used at an optimum level. We can, of course, multiply the examples in that sense. There are also some problems regarding the dispensing of drugs. With switch to e-prescription, computer-based or computer-supported systems actually created a positive outcome here, but there are also some negative aspects to it. There is an innocent interpretation of prescription, which is a factor. Again, retrieval of wrong ingredients. Usually, these are because of manually prescribed drugs. There could be inaccurate counting or compounding. For example, in the prescription it says 2 times a day, but the patient might not understand that or inaccurately think that they should use it more or less. And there are some unsanitary procedures. These are the factors in that sense regarding the dispensing of drugs. So when you look at the rationality criteria and optimization, what are the most important things? Of course, we start with the selection of drugs. This is the main factor that we base ourselves on. For the rationality criteria, we can say selection of drugs, determining drug logistics, which is another very important item here on this list, the prescribing process, and the consumption of the medication. The prescription response processes, the consumption of drugs, drug information support, and rationality in drug management. These are the basic criteria of rational drug use. So what are the drug use indicators when we talk about rational drug use? What should we look at? What is important? Here there are different classes of indicators which start with prescribing indicators. What does this mean? First of all, there is an average number of drugs in prescriptions. What does this mean? This means that in 2 different clinics, for example, there could be 20 prescriptions per day, and from each clinic. An average number of drugs in prescriptions in one clinic could be 2 and the other one could be 4. If the number of patients are the same for both clinics, this actually means that there is an irrational drug use in this case. The other indicators is that percentages of drugs prescribed by generic names. So what does this mean? It means, let's say, we have 2 depression clinics and more prevalently paroxetine is prescribed in one of them and another drug is prescribed in the other one. So when we look at all the factors and all the costs of medications, drugs, or the patient indications, the drug indications based on patients, these are all determining factors, and generic names should not be really constitute the reason or basis of prescription. There's also an average prescription time of antibiotics. This prescription time of antibiotics actually show us the drug use habits of populations. The other thing is the percentage of drugs prescribed from essential drug lists. This is not really a very important case for us, for our country, because the World Health Organization presented a drug list, essential drug list, in a global sense. There is a usage of that, but in our country it's not that common. These actually mean that there are some essential drugs which are actually proven to be effective, their efficacy and is proven, and costs are lower. So these essential drugs, no matter what, you have to have in your depot, in your storage. But it is not the case for our country, and there are some other indications, other indicators. First of all, patient care indicators. This is another class. So it includes subjects such as average consultation time, average drug intake time, and also the percentage of correctly labeled drugs, and also patient information about drugs. Another class is the facility indicators, because these indicators may not be always be about you or the patient. This could be about the industry or about the institution that you are working at. For example, do you have access to essential drug lists or formulary, or do you have accessibility to critical drugs? These are most important factors that affect rational drug use. I want to move on to examples now. Rational drug use, when it first came to being, it was based on antibiotic use, and it was one of the, it's the bleeding wound of our sector. It is a problem, a big problem worldwide. Why is this important? Because antibiotics actually over time may cause resistance. For example, people could develop resistance to certain antibiotics and they become useless after a while. When you look at this map, as it turns towards blue, it means that the drug use, antibiotic use, is increasing, and in the yellow areas or light yellow areas, the antibiotic use is less. And in lower respiratory tract infections in children, you can see the antibiotic use in our country. It was about 60% antibiotic use in 60% of the children, pediatric patients with lower respiratory tract infections. And you can see that it becomes less and less used. It means that there's a drop in the antibiotic used over time, over years. And this means that as a society, as a community, our population, our country learns the importance of using, not overusing antibiotics. There are some critical areas. When the population is more than or less than 10 people per kilometer, these populations or countries are not included in this research. When we come to the 2018 data, we can see that Turkey is one of the bluest countries, which means that we are among the countries that use antibiotics the most. There are some African countries and Greece, and these are similar in the similar range, but other countries you can see the antibiotic use is much less. And you can also look at it from this perspective. What happens when we use or when we overuse antibiotics? Why shouldn't we use them too much? Because if you try to use antibiotics in fighting against some organisms, it actually transforms them into bacteria and superbacteria. So if we continue inappropriate or irrational use of antibiotics, we will not be able to treat any microbic disease with antibiotics. So the World Health Organization actually published in 2012 some bacteria that needs to be included in the lists for we need antibiotics, new antibiotics for. And these are 12 drug-resistant priority pathogens. So this means that if we cannot come up with antibiotics to use against them, we won't be able to treat them. And we are actually becoming more and more aware of the problem. And Turkey is actually among one of the highest use of antibiotics, and we are aware of that. And Republic of Turkey, Ministry of Health, and TİTCK, which is Turkey Drug and Medical Devices Institution, and Department of Rational Drug Use. We have efforts towards rational drug use. These are the parties or the efforts in Turkey towards rational drug use. And also people are trying to be informed and trained and educated about unnecessary antibiotic use. So was this effective? Let's look at the official statistics in 2017. The drug use ratio here is, or the daily dosage unit is the basic unit here. We are the second country in the world with 35.3%, which means that among 1,000 people, daily amount of antibiotics used is 35.3. We are the second in the world, and the only higher percentage is in Greece. And when you look at the OECD average, you can see that it's around 23. And in 2020, there was another statistics graphic, as you can see here. there was a decrease by 3.1%. This is a really huge percentage. Of course, we are still above the OECD average. Of course, this is not enough. It should be decreased even more because we are still among one of the highest users of antibiotics around the world. But the efforts are actually paying off. So, what about psychiatry? In Psychopharmacology Congress, of course, it could be a little bit weird to hear about antibiotics. But let's look at the psychopharmacology and where we are at with that. Of course, antidepressants are the most used kind of drugs in the psychopharmacology area in the population. So, between 10 years, the antidepressant drug use was compared in countries around the world, and in Turkey you can see that in 2009 the ratio was about 29, but in 2019 it increased to 49. So when you look at the OECD average, we use more antidepressant, but the increase is higher. For example, the use in OECD countries was from 50 to 63. So this means that our increase was much faster. So if we continue this way, we will be the leader in unnecessary antidepressant use. Is it only our country's problem? No, of course this is a problem worldwide, and the course that the world is on about antidepressants, it's usually the same all around the world. Another hypothesis is that the world is becoming a much unhappier place. So in England, there was a research done in England. It's a very long duration research. When you look at the left side, you can see the UK population. There's not much of a change. It increased from 50 million to 59 million as population. But when you look at the use of antidepressant, there was 10 million boxes used, and now in 2019, with the last results, it increased to 70. So from 10 million to 70 million boxes in 10 years, and in 20 years, sorry. And on the right side, you can see that in the golden standard class, which is the SSRI, there is the huge increase in there. Of course, we can ask ourselves, from 91 to 2018, does this increase depend completely on irrational drug use? Of course not. It is not the only factor, but the prevalence of depression increased, and SSRI efficacy was proven, and their use in other psychiatric disorders increased, so the ratios increased in line with those. So what about the situation in Turkey? Let's look at the Psychopharmacology Association research or studies from the past between the years 2007 and 2012. The red columns show the first prescriptions, and the blue ones show the first prescriptions and the continuous or the continuing prescriptions. Of course, there is a continuous increase in antidepressant use and prescription. As you can see on the y-axis, the total prescription is shown in millions as a unit. And in that study, They also looked at the prevalence, for example, if the prevalence of prescribing antidepressants is correct, or should it be that way. So it was about 15 million. But when you look at the number prescribed, you can see that it is much higher than what needs to be prescribed. So do only psychiatrists prescribe these medications? When we look at that, we can see that as years go by, antidepressants were prescribed by practitioners and also family medicine physicians. So not only psychiatrists, but other physicians also prescribe antidepressants, such as family physicians. And this is actually bringing new questions in mind, such as our healthcare system and who prescribes these medication.
So, is it really credible that depression increased that much in the UK 7 times, for example, also in our country as well? Is it really due to depression? In this study, the change in depressive disorders and the prevalence of depression is reviewed. And in the countries like Turkey and some African countries, they are in pink color, which signifies that the increase has happened between 50 to 100%. But there are some places like Qatar that the increase is 600%, or Letonia is 30% increase, the lowest. So the prevalence of depression is increasing. This is something we have to accept, and the number of depressive disorders patients are a lot more than the ones in 1990s. But the prescription of antidepressants today are a lot more than the 90s. But what happens if we use a lot of antidepressants? So if we do that, we can see the results with this meta-analysis. As polypharmacy increases, the depression risks increases too, resistance increases as well. So particularly when the patient takes more than 5 drugs in polypharmacy, the risk increases, and the drugs do not have much effect, and the risk here it is shown increases by 1.5 folds. And the antipsychotic drug use should be increased, should be reviewed as well. And the antidepressants are mainly the reasons of this increase in depression risk. Antipsychotic drug use also increases too, but this is not as serious as the antidepressants. Therefore, maybe we can assume that the overprescription kind of is specific for antidepressants. And the prescription numbers are evaluated for antipsychotic as well. And the difference is not much here. It's not really high here. And antipsychotics are a better condition in Turkey. And the physicians who prescribe antipsychotics are quite low. And the psychiatrists prescribe, and the difference between the antipsychotics and antidepressants are quite low. And the irrational drug use and its prevention. To summarize our topic, we have to, first of all, create fundamental drug lists. It is available in WHO lists in the primary care. We can see the fundamental drug lists, and some groups of drugs are very few for antidepressants, and only the efficiency and trustworthiness are proven for these drugs. This is the reason that they are listed in the fundamental drug list, and therefore the number of drugs are very few in that list. Here we see the variety of drugs. You can see that the variety is very low as well. And the fundamental drug lists does not only exist in WHO. It has, but there are many fundamental drug lists, country by country, because it is a very, big load in the budget sometimes. The graph here shows us that the countries who are painted with blue have fundamental drug lists, and we can also add the United States of America here, even though it is shown as gray. But in Turkey, we do not have a fundamental drugs list or essential medicines list. When we see the psychiatric agents, we see the ones on the list. So what else can we do to prevent irrational drug use? We can use the e-prescription guideline published by WHO. This is a guideline for prescribe better medicine, better drugs, and better prescribed medicine. The articles to pay attention to are listed here. If you do that, you can prescribe better drugs. It's also available in Turkey as well. It's not really up to date. It was translated in 2007, as far as I know. But the general logic is, okay, and still it can be updated regularly. As summary, the rational medicine, the rational drug use is proceeding like that. The step one is to identify the patient's problem and to recognize the need for action. And then the identification of the motivational factors of the patient and the needs of treatment, etc. Step two, planning of the diagnosing the disease and planning the treatment, and prescribe correctly, inform the patient correctly, and lastly, to monitor the treatment and follow-up of the patient. The conclusion is that the rational drug use covers every stage of the process, from the manufacture of the drug to its disposal, to its consumption. It is an important fact. Incorrect and unnecessary drug use is a serious problem, and it affects the treatment costs and public health in all the countries in the world. Therefore, it is extremely important to raise the awareness of the public and healthcare workers and professionals about the rational use of drugs for the future. That's all I have to say. Thanks for listening to me.